Hello and good afternoon, all of you. Welcome to Quest. I'm saying that because there are a lot of you who are you have been a part of Quest for the last 2 weeks, but really speaking, the lectures were open to all. But today we are talking exclusively with you, all of you who are part of students of Quest. I would again like to thank our batches from Mumbai and Pune. Before I start this, uh, I've got an amazing response from a lot of students across the country, and a lot of them felt that they kind of got this help at the right time, and it was all possible because of our students in Mumbai and Pune. Of course, there were some of you who have written to us now that these lectures should have been streamed for a longer period, and I completely respect your opinions. I have immense respect for someone saying that. But of course, there are going to be limitations to how much we can do at this moment. As you all know, the new batch is starting from today, and from next today and tomorrow, there is still going to be an overlap between the topic because I'm continuing with nephrology, just a small section, and then the second topic also I thought goes in the flow, and I'll continue that with two batches together. But from Thursday onwards, the curriculum will separate out. So I'll be practically taking two lectures, 2 hours lectures in the morning or 1 hour lecture in the morning and second in the evening. And it will become really tough for me to manage all of that. The situation now does not look very encouraging to me. So please stay back at your home. If you have that alternative right now, use that option. We are going to be at the forefront. We are at the forefront as doctors to handle this. I hope I am able to talk to you every day this way. Of course, there is no certainty as the time goes forward. I do not mean to sound pessimistic here. I, of course, mean to sound that we are at this moment the soldiers of this war, and we need to prepare well. You guys are going to take that war forward if this prolongs. Me, my generation is doing what we should be doing at this point. So I'm right now at my clinic. I am here every day, and whatever help we can be of to patients in this community, we are trying to do that. Right. So nevertheless, so let's start from here again, and I'm going to say what is the plan for today and tomorrow. So today we are going to complete two small parts of glomerulonephritis that I could not complete last time. So we are going to talk about IgA nephropathy, and we are going to talk about Goodpasture syndrome. Two small but distinct but important topics nevertheless. And then we will start talking about hypertension, a very common topic, a very difficult topic also at times I feel, and also a very simple topic if you think of its management. It's actually very often straightforward, right? So let's start first with where we had left last time. Let's start by looking at patients of IgA nephropathy. So please start writing down. I'm talking to you about IgA nephropathy. Like, give me a second. I just missed out on something I should have done before the lecture starts. Yes. Okay. So I hope all of you are able to see my screen that I'm sharing with you. Okay. So we are talking about IgA nephropathy. Now, IgA nephropathy is also known by another name, that is Berger's disease. So please make a note of this. We are talking about IgA nephropathy, which is also known as Berger's disease. Berger's disease, right? Now, IgA, as most of you are aware, IgA is technically immunoglobulin A, which is usually produced from the mucosa. So whenever there is going to be an infection or any allergen which is going to be encountered by the mucosa, when I say mucosa, it is very often the respiratory mucosa or the GIT, the gut mucosa. If any of them encounters an antigen, very often the antibody which comes to respond is IgA. So please make a note of this. Under normal circumstances, there are two sources of IgA. Please make a note of this, that under normal circumstances, there are two sources of IgA. The first and a very common source of IgA is the mucosa. The first and a very common source of IgA is the mucosa. So in response to either a stimulation of the respiratory mucosa or the GIT, the gut mucosa, there is going to be production of IgA, and this IgA is going to be polymeric IgA. It's also known as PIgA. So polymeric IgA is what is usually formed from the mucosa. But there is also formation of IgA from the bone marrow. This is the steady state formation, and this is monomeric IgA. right? So this is normal. Patients normally would have IgA production from polymeric IgA, which is coming from the mucosa, and monomeric IgA, which is coming from the bone marrow. Now, patients who have this IgA nephropathy have a very unique problem. Please make a note of this. Patients who have IgA nephropathy, they have a very unique problem. The first problem is that there is a decreased production from the mucosa. The production of IgA from the mucosa has decreased, but there is an increase in the polymeric IgA coming from the bone marrow. So the source has changed. So there is an increase in polymeric IgA coming from the bone marrow. From the mucosa, the production has decreased, but from the bone marrow, the production has increased. The second problem is the IgA that has been produced now. This IgA is also abnormal. Please make a note of this. The kind of IgA that they produce has an abnormal attachment of sugar. So there is an abnormal glycosylation. So there is an abnormal glycosylation of the IgA. Now, why did this happen? There are two possible theories of why did the abnormal IgA production start. So the source has changed and the type of IgA has also changed. One is it is probably genetic. So probably it is genetically determined that there are some individuals who are going to be at higher risk of having this. So at some point in their life, they would make a switch and they would start forming abnormal IgA. But a much more likely is that this mucosa, which was kind of receiving different antigens, one of those set of antigens could have been viruses, and those viruses triggered the immune system in a wrong way. So please make a note of this. A big possibility is this is done as a response to viral infections. Please mark this as important, that a big possibility is this shift happened because of a stimulus coming from viral infections. Now, all of you should know this. Viruses, I mean, we are right now in amid a pandemic right now, but you should also know this. Viruses have this notorious thing that they play with our immune system in a really bad way. Most of the viral infections tend to cause a lot of damage, not directly, but very often because they kind of trigger the wrong arms of the immunity and set the immune system going berserk. Right? The immune system really goes mad and destroys itself. That's very often what happens with viruses. With COVID also, we are seeing that as a big problem, that the immune responses that are being mounted by the body, by the host, are actually the ones which are probably causing much more damage. So there have been theories, if you have heard about COVID also, that immunosuppressants might have a role there. So, I mean, so on and so forth. So over here also, it's a problem that viruses perhaps are triggering the immune system to start IgA, abnormal production of IgA and overproduction of IgA. Now, these infections, needless to say, are very often, again, respiratory, that is very often URTI or GIT infections. So these viral infections very often which trigger are either URTI infections or they are GIT infections. So a patient could have history of URTI or that is sore throat, cough, or could have history of diarrhea, right, preceding this. Now, once there is an abnormal IgA which has been formed, that is going to cause a couple of problems. First, please make a note of this. Once there is an abnormal IgA which has been formed, that abnormal IgA, now understand, let us just take an example over here. Let us say that this is the normal antibody that I should have had, right? For some reason, this antibody now has this abnormal glucose moiety attached to it. This antibody itself has got abnormally glycosylated. What could happen is my body might realize that this antibody doesn't look normal. It starts treating this abnormal antibody as its new antigen. What I'm saying is you had an antibody, but that antibody has changed its structure. It's a protein thing, it changes structure. Now, after it has changed its structure, the rest of the body might say this abnormal IgA is behaving like a new antigen and it might produce antibodies against IgA. Please mark this as important, that these patients might start developing antibodies against IgA. They might start developing antibodies against IgA. Now, when we talk about rheumatoid arthritis, you will find that in rheumatoid arthritis also you have a similar principle, though they are not related to each other, but a similar principle is happening there also. In rheumatoid arthritis also, you have anti-immunoglobulin antibody. And those anti-immunoglobulin antibody, those of you who have read rheumatoid, you might know that the anti-immunoglobulin antibody in rheumatoid arthritis is called rheumatoid factor. So please make a note of this. This is a rheumatoid factor-like substance or a response. Please make a note of this. This thing that is happening, that there is an anti-immunoglobulin antibody, is a rheumatoid factor-like response. Right? So you'll very often read that these patients of IgA nephropathy have a rheumatoid factor-like response. What does that really mean? That the body has recognized its IgA as abnormal and has created another antibody which is kind of attaching against it. Right? This another antibody could be IgM or IgG. So this could be IgM antibody or this could be an IgG antibody. Remember, if this is what is happening, there is an antibody against an antibody, this is behaving like an immune complex. So please make a note of this. So the first problem why there is nephropathy is now they start behaving like there is an immune complex. Second thing that will happen is this immune complex or sometimes the abnormal IgA. So either the immune complex, that is antibody with IgA, or only the IgA. One of them will get deposited in the mesangium. Please mark this as important, that the damage to these patients very often is in the mesangium. If someone is to ask you IgA nephropathy, the site of damage, maximum damage happens to mesangium. The site of damage, maximum damage occurs to mesangium. I'm sure all of you remember what is mesangium. I'm going to show it again. You have the afferent and the efferent arteriole. These are the capillary loops. These are the podocytes outside. You have the parietal epithelium outside, and this orange color structure over here, that is the mesangium. And you will find that in these patients, there is an deposition of IgA within this mesangium. So it is within the mesangium that maximum immune complexes as well as IgA start getting deposited. Right? So please mark this as important. These patients have deposition within the mesangium. Apart from the mesangium, there can be deposits within the or below the endothelium. So there is IgA deposits within the mesangium and there is IgA deposits within the endothelium. The response, that means this response is therefore referred to as mesangio proliferative glomerulonephritis. So if someone is to ask you what kind of glomerulonephritis is IgA nephropathy, it is mesangial-proliferative glomerulonephritis. I'm sure you remember from the last time we had said the word proliferative means either the mesangial cells or the endothelium is growing rapidly. It's distributing rapidly because of an inflammatory response. So there is a mesangial-proliferative glomerulonephritis, right? So I repeat, there is an antibody formed against the antibody. There is an IgA which is going to damage the mesangium and will damage the endothelium. We are going to say that this is going to be primarily what is going to cause a damage to these patients. And third, remember there is immune complex activation. So these patients are also going to have complement activation. Very often there is activation of complement system as well. Right? So very often there is going to be activation of complement system as well. In some of these patients, please make a note of this, in some of these patients, there could be activation of substances like TGF beta. TGF beta could be increased, and TGF beta, if it is increased, it causes glomerular sclerosis. TGF beta could be increased, and TGF beta being increased causes glomerular sclerosis. So these patients can have a risk of developing CKD. That risk isn't really very high, but they can carry the risk of developing CKD. IgA nephropathy is an important condition. Let's try to go through it again. I repeat, IgA has two sources, mucosa and the bone marrow. Patients of the nephropathy part spectrum have an abnormal predisposition or a viral infection to which they respond, leading to increase in polymeric IgA coming from the bone marrow, as well as change in the structure of the IgA. Now the body starts making an antibody against the IgA. This IgA or the antibody or the immune complex get deposited within the mesangium. They cause mesangioproliferative glomerulonephritis. They activate the complement and therefore destroy the basement membrane and destroy the endothelial site. They can sometimes lead to activation of TGF beta, leading to glomerular sclerosis and CKD. Right? But please remember that production of IgA and glomerulonephritis doesn't occur only in IgA nephropathy. There is one more condition which is very closely related to IgA nephropathy. Please mark this as important, that there is one more condition that we are aware of which can have very similar pathophysiology. And that condition very often occurs in children. So please make a note of this. There is another condition which is very similar to IgA nephropathy. It has renal manifestations, and its renal manifestations are exactly same as IgA nephropathy. It has renal manifestations. If you do a kidney biopsy in that patient, they will have exactly the same thing in the kidney. But they have classically a triad. In a child, usually a child of less than 5 years, these patients are going to present with a rash, a palpable rash, usually on the lower limbs or the buttock. Some of you might have realized what I'm talking about, that these patients might have a renal picture similar as IgA nephropathy. They might have a rash, very often a palpable rash on the lower limb or the buttock. Two, they are very often going to present with arthritis, and this is going to be polyarthritis, multiple joints being involved. And three, part of the triad is they are going to have abdominal pain because they are going to have intestinal vasculitis or GIT vasculitis. This triad is known as Henoch Sconlin purpura. Please mark this as important. HSP, very often a self-limiting condition, is thought to be an extension of IgA nephropathy. Please mark this as important, that IgA nephropathy and HSP are thought to be kind of cousins of each other. We have not been able to exactly prove till now what is the relation between the two. Are they really the same disease affecting different organs, or are they two completely different disease? But whatever we know till now is it looks like HSP is a disease that occurs in children, has multiple system involvement, including the kidney. IgA nephropathy, on the other hand, is a disease, as we are going to see, which occurs in adults, but affects exclusively the kidney. But point to remember here, please mark this as important, that IgA nephropathy and HSP, Henoch Sconlin purpura, which is a self-limiting condition in kids. It can be a progressive condition in adults if it occurs, but in kids, very often where it affects, it is very often a self-limiting condition. HSP and IgA nephropathy could be part of the same spectrum. It could be maybe the same disease. We are not very sure. It could be the same disease, one limited only to a kidney, one being multisystem, right? I'll come to what are the other differentials of IgA nephropathy, but I had to mention this because whatever we have written down till now can happen in one more disease, that is HSP, right? Now, please make a note of this. What are the clinical features of IgA nephropathy? How is the patient going to present to us? What are the clinical features of IgA nephropathy? Well, first, IgA nephropathy almost always occurs in young adults. IgA nephropathy almost always is going to occur in young adults. It has a slightly more male predominance compared to women, so men more than women. Third, these patients can present to you in variety of forms, but the commonest presentation of IgA nephropathy is gross hematuria, that is macroscopic hematuria. Please mark this as important. Patients are typically, they can have variety of presentations, but the classical presentation is that the patient comes with gross hematuria. Gross hematuria means there is macroscopic hematuria. Patient will tell you that he passed blood in urine. This gross hematuria episode is preceded by an infection. So this gross hematuria ke pehle, there will be history that the patient had infection, either a sore throat or GIT infection, either the sore throat or diarrhea. Right? So in the past, patient had sore throat or diarrhea. Yeah, but do you remember that we have mentioned some other condition where it wasn't an adult really, it was a kid, and the kid had infection, something like a sore throat, pharyngitis, followed by cola colored urine. We called it post streptococcal glomerulonephritis, right? Remember that? So how will I know that this person who is also telling me that there is a sore throat and then he's passing red color urine or dark color urine, he's having gross hematuria. So how will I really know that this patient is just hematuria coming because of IgA nephropathy and not post-streptococcal glomerulonephritis? How do I differentiate the two? Well, there are many other ways I will be able to differentiate, but one big difference: pharyngitis to nephritic syndrome. In post-streptococcal glomerulonephritis, onset of pharyngitis to onset of glomerulonephritis was at least 3 weeks, average 1 to 3 weeks. Here, the duration is 24 hours. Please mark this as important. IgA nephropathy, you have to take the history very carefully. The history of sore throat would be yesterday. Yesterday I had sore throat and today I passed red color urine. Yesterday I had diarrhea, today I passed red color urine. The history of infection is within 24 hours. Please make a note of this. So IgA nephropathy would have a history of infection followed by hematuria. That's the commonest presentation, and the history is going to be within 24 hours. Second, please remember, IgA nephropathy, this episodes of hematuria could occur recurrently. Please mark that as important. Patients of IgA nephropathy could have recurrent hematuria. So the first way that IgA nephropathy presents to us is that the patient has gross hematuria. But at this stage, please make a note of this. If a patient has gross hematuria, patient does not very often have any other features. So no proteinuria, no hypertension, no oliguria, so doesn't have nephritic syndrome. Please make a note of this. At this stage, or just this much presentation, patient might come to you only with episode of hematuria. He'll just tell you, yes, I passed red color urine, and the episode very often self-resolving within 3 days. Most of the patients would recover within 3 days. You do nothing and the patient still recovers. Right? So it was an immune response to a viral infection, maybe in a genetically predisposed person, and the patient passed urine for 3 days, was red. That's it. Patient might recover, but might have it again and again every time he gets an infection. Majority patients, remember, have this gross hematuria. Patients can also have other presentations. Please make a note of this. Some patients might come to you with long-term microscopic hematuria. So they don't have one episode of gross hematuria, but they continue to have long-term episodes of, or if you keep on monitoring this patient, you find that, oh, he's repeatedly having microscopic hematuria. Something that the patient does not complain because he or she doesn't realize. But if you keep on doing his urine routine, you find there is microscopic hematuria. Such patients have a high risk of progression to CKD. Please mark this as important. If the patient has repeated hematuria later in life, they do have a high risk of progressing towards CKD. Third presentation could be frank nephritic syndrome. Please mark this as important. Third presentation could be that the patient comes with nephritic syndrome, then he fulfills all your criteria. He has azotemia, he has hypertension, he has hematuria, he has proteinuria and all of that, and so he falls into nephritic syndrome. That could be the third kind of clinical presentation. And fourth and the most dangerous is patients can present sometimes with rapidly progressive glomerulonephritis, that is crescentic glomerulonephritis. Please make a note of this. Some of these patients can present with RPGN. So I'm telling you from the commonest to the least common, but mild to very severe presentations of IgA nephropathy, that they can present to you with rapidly progressive glomerulonephritis, right? Now, diagnosis of IgA nephropathy, it's very often a straightforward call. If you get a patient, a young adult saying that I had sore throat and followed that I had hematuria, you will have to think of IgA nephropathy. Please make a note of this. IgA nephropathy world over, it's not actually that common in India per se compared to the Western population, but world over, the commonest cause of glomerulonephritis in adults is IgA nephropathy world over, not in India specifically. Right? I'm actually not sure what of them should be called the most common in India. I am really not sure of that. So I couldn't find a reference to that. But whatever I've seen, IgA nephropathy isn't that common in India compared to the other ones. So please make a note of this. World over, the commonest cause of glomerulonephritis in adults is IgA nephropathy. Right? You should ask this question to your professors in your college as to what do they believe is the commonest in India. I'm not sure what's the exact answer to that question. In my practice, the commonest I see is actually lupus nephritis because I see a lot of rheumatology, but I can't extrapolate that and say that that's common everywhere. Where I got trained over there also at AIMS also, the commonest I used to see was lupus nephritis. Here also today I see lupus nephritis. So there is a bias in what I see. I have not read what is the commonest in India, so I cannot tell you that answer. You should ask your professors wherever you are as to what they believe is the commonest happening in India. But world over, it is IgA nephropathy. I don't think IgA nephropathy is that common in India, right? So I'm just leaving that one part open for you to discuss with your professors wherever you are, right? Now, diagnosis of IgA nephropathy can be done on two things. One is serum IgA level. A lot of them would have elevated serum IgA level. But without a doubt, it requires biopsy. IgA nephropathy is a biopsy diagnosis. IgA nephropathy is a biopsy diagnosis. And remember, in biopsy, we had done the histopathology, we had done immunofluorescence and electron microscopy. You don't very often get the electron microscopy. But on immunofluorescence, we need to document IgA deposits in the mesangium. Please mark this as important. So mesangial-proliferative, that part you will see on light microscopy, that the cells are proliferating. Okay. But IgA has been deposited is something that requires you to do immunofluorescent assay. If a patient has treatment-wise, if a patient has a single episode, conservative management. You don't need to do anything. Hydrate the patient well, take care of his other parameters, BP, electrolytes, just keep a watch on him. Don't do anything proactively, just monitor him for all possible things that can go wrong. So if it is a single episode, conservative management. But if the patient has nephritic syndrome or RPGN, then steroids plus cyclophosphamide. So if the patient has nephritic syndrome and or RPGN, then steroids plus cyclophosphamide. Steroids plus cyclophosphamide. In case of RPGN, we also consider, if you remember our discussion the last time, I told you in RPGN, you also consider some other strategies. We consider plasmapheresis. If the patient has RPGN, rapidly progressive glomerulonephritis, think of rapidly progressive glomerulonephritis as patient presenting with AKI because of intrinsic renal, but worsening very fast. Within a week, the patient is so bad that requires dialysis. That is RPGN, right? So if you get an RPGN, you might have to consider plasmapheresis, right? So that is that I wanted to discuss with you about IgA nephropathy. Before I complete that discussion, I would want to show you a list. It's a big list, but I would want you to copy it down. Please write down what are the differentials of IgA nephropathy. Now, why is this list important? Well, it is important because IgA deposits in the kidney are not specific to IgA nephropathy. So you need to have the clinical syndrome with the biopsy. You can't just do a biopsy and show IgA and say it is IgA nephropathy. And sometimes the diagnosis can be really tricky. That you thought it is IgA nephropathy, but only later in time you realize, oh, it was not IgA nephropathy. It is possible. So it's sometimes a difficult diagnosis because there are other conditions where IgA could be elevated and deposited in the kidney. So I'm going to give you that list. It's a big exhaustive list. So please make a note of this. So just give me a second. Yeah, please make a note of this. What are the other conditions where IgA could be deposited within the kidney? HSP is something I have already discussed with you. Please write down other conditions. These could be rheumatic conditions. These could be GI conditions. Some of them could be malignancies. Please make a note of this. What are the conditions where IgA is deposited within the kidney? I really do not have a way in which I can help you to kind of mug this up. I wouldn't even want you to mug this up. I just want you to remember that there are differentials over here. It's more for the pathologist to give you an idea that, okay, there is an IgA deposit here, look for other differentials, and then you might have to consider this if the clinical profile doesn't fit in, right? While you copy this down, I'm going to see if there are any questions that have been posted for me. Oh, yes, there are. In a patient with IgA nephropathy with long-term microscopic hematuria, what are the chief complaints? There are no chief complaints. That is why I use the word, you are monitoring that patient. The patient doesn't complain of anything. You thought that you should look for his hematuria. So this could happen in two ways. Either the patient had an episode of gross hematuria and you decided that I want to follow this patient every 3 months, which is what we do, and you realize, oh, gross hematuria to chala gaya, but the microscopic hematuria is continuing. That's one possibility. Another possibility, a young individual does a urine test for something else, maybe for insurance, maybe because his company offers him to do it as a health checkup. He does it for some other reason, or she does it for some other reason, and you find hematuria. And you say, okay, nothing doing, you have just one urine report of hematuria, wait and test it after a month. He comes after a month and he still has hematuria. Then you say, okay, let's wait and let's do it after one more month, and you again find that there is hematuria. Now that is a patient where you start evaluating. You usually want to wait till the third report. By the second report itself, you'll start evaluating. But one of the reasons could be then patient has IgA nephropathy. Of course, there could be other reasons of hematuria, like hypertension is a big reason, but you have to think in terms of IgA nephropathy. If bone marrow produces only monomeric, how can polymeric be produced by IgA in IgA nephropathy? Now, again, it isn't really only. Do not get me wrong if I have not clarified that. It is never always. Remember that rule of medicine. So it isn't that bone marrow produces only monomeric. It is predominant monomeric, and mucosal is predominant polymeric. Now, why does such a shift happen is beyond us. We really don't have answers to that. If we realize why that shift occurs, we might be able to identify molecules which cause those shift and block those molecules. When that occurs, I will have a specific therapy. Today, I don't have that specific therapy, but today we have reached a stage where we know that such a shift does occur, that patients do shift from a bone marrow producing primarily monomeric towards primarily polymeric. Again, but this is self-limiting. One can always ask, why was this self-limiting? We don't have answers to those questions. Why is the body behaving this way for some time and then going back to its normal self? We really don't know that answer. Okay, so I don't see any one of you typing any question. Let me go to the next one, and if there are questions, I can take them. Please write down Goodpasture syndrome. Now, this is a small discussion, but again, an important disease, Goodpasture syndrome. Goodpasture syndrome. Goodpasture was the person who described it for the first time. But at that time, of course, he did not call it Goodpasture. It was close to, I think, 50-60 years later that someone thought that this should be called Goodpasture syndrome. At that time, nobody called it Goodpasture. Now, that's not the part that you write down. Please make a note of this. Goodpasture syndrome, again, who's going to be affected? There are two age groups at which we see Goodpasture syndrome. There are two age groups at which we would see GPS or Goodpasture syndrome. Most of the patients are young men. Please mark this as important. Where should I think of Goodpasture syndrome? Most of these patients are young men, and with another very strongly associated risk factor, smoking. If you get a question in your MCQs, if you get a patient in your wards or ICU, very often this is an ICU patient. If you get a patient who is fulfilling this, young men with history of smoking and RPGN, rapidly progressive glomerulonephritis. Please mark this as important. This is how these patients present to us. Young men with a history of smoking and rapidly progressive glomerulonephritis, along with a history of hemoptysis, bleeding in the lung. Please mark this as important. The classical presentation of Goodpasture syndrome is these are young men with a history of smoking, presenting to us with a rapidly progressive glomerulonephritis and history of hemoptysis. They have bleeding inside the lung. The hemoptysis is associated with diffuse alveolar hemorrhage. Please mark this as important, that there is hemoptysis because there is diffuse alveolar hemorrhage. And Goodpasture syndrome is believed to be a type of vasculitis. It is an inflammation of the vessel in the glomerulus, and it is inflammation of the vessel in the lungs. Please mark this as important again, that Goodpasture syndrome can also be thought of and classified as a form of vasculitis. It is a form of vasculitis. And this vasculitis is triggered because of anti-GBM antibodies, anti-glomerular basement membrane antibodies. This vasculitis is triggered because of anti-glomerular basement membrane antibodies. And these anti-GBM antibodies, the epitope, or what are they against, is against the alpha 3 unit of NC1 domain of collagen 4. Please mark this as important. The antibody is against the alpha 3 unit of NC1 domain of collagen 4, which is a part of the glomerular basement membrane. But this is also a part of the alveolar basement membrane. Also a part of the alveolar basement membrane. Right? And because of this antibody, there is a destruction of this basement membrane, and patients present with a rapidly progressive glomerulonephritis. They present with crescentic glomerulonephritis. That is why we call it RPGN, or that is how the RPGN presents to us. And please make a note of this. These patients also very often have, in elderly patients, they might present to us with just nephritic syndrome. In young adults, they present to us with alveolar damage also, so they present to us with hemoptysis. But in elderly patients, they might present to you with only nephritic syndrome, not with pulmonary manifestations. So we can say that in young adults, these patients present as pulmonary renal syndrome. Please mark this word as important, that Goodpasture syndrome can present to us in young adults as pulmonary renal syndrome. Remember, pulmonary renal syndrome is not an always feature of these patients. It is a feature seen in young adults. In elderly patients, patients could present to you with nephritic syndrome. Right? But as someone of you had asked me during one of the earlier lectures of glomerular diseases, I told you that the patient, or maybe during AK, I don't remember where exactly that question came to me, but it was a very interesting question, that if a patient comes with hemoptysis and renal shutdown, that is hemoptysis and AKI. Remember, RPGN is nothing but a rapidly coming AKI because of an intrinsic renal cause. So if a patient comes with hemoptysis and AKI, should I always think of GPS? No. Please write down what are the differentials of this pulmonary renal syndrome. What are the differentials? So one is GPS, no doubt, but GPS is not common. Anything else? So I have seen, I would say, close to 10-15 patients of pulmonary renal syndrome till now. Yeah, by itself, it's not a common thing. And none of them was actually GPS. I have not seen a single GPS till now. I'm not saying GPS does not exist. I'm just saying out of the 10-15 that I have seen of pulmonary renal, majority, none of them was GPS. Majority were complicated malaria. Please mark this as important. Patients coming with rapidly progressive worsening AKI with hemorrhages somewhere else could be malaria. It could also be leptospirosis. It could also be leptospirosis. It could also be sepsis, which is causing AKI, with DIC, disseminated intravascular coagulopathy, DIC, a complication of sepsis. So it could also be sepsis with DIC, disseminated intravascular coagulopathy. So it could be sepsis with disseminated intravascular coagulopathy, DIC. Right? It could also be other forms of vasculitis which are affecting the kidney as well as the lung, like Wegener's granulomatosis. It could also be Wegener's granulomatosis, where the patient comes with hemoptysis and RPGN-like picture. Wegener's granulomatosis. And at least in my experience, if it was not malaria, the second big reason why I saw patients coming this way was actually lupus, SLE. Please mark that one as important. It is not a common feature of SLE, but overall SLE is far more common than GPS or Wegener's. So SLE, systemic lupus erythematosus. Right? So these are the differential diagnosis of Goodpasture syndrome, or rather hepatopulmonary syndrome. Right? Diagnosis of Goodpasture. can be done, if you remember our initial discussion, without a biopsy. You can do it by doing an anti-GBM antibody in the serum, in the blood. You can do an anti-GBM antibody that can help you in diagnosis. But if by chance you don't get a diagnosis over there, you might want to do a renal biopsy. If you don't get an anti-GBM antibody, you might want to do a renal biopsy. And when you do a renal biopsy, again, the best way to diagnose this is to show immunofluorescence, because the antibodies are now targeting the basement membrane. So please make a note of this. There is linear means along a line. There is a linear immunofluorescence along the basement membrane. So what do I look for in the biopsy? There is a linear immunofluorescence. Linear means along a line. There is a linear immunofluorescence along the basement membrane. That is what I'm looking out for, right? Remember, very often I will not need to do that, unless, of course, if I was confused, okay, maybe this is anti-GBM syndrome, that is GPS, or maybe it is lupus. In lupus, I need a biopsy. So if I'm confused, I might do a biopsy. But if I find the anti-GBM antibody present in the blood, I might not want to do it. But if I do it, here I will see that there is deposits happening along the glomerular basement membrane. Treatment over here is steroids plus, so we have to give high dose steroids to these patients. These are RPGN, they are progressing rapidly. You don't save them now, you might lose the patient. Very often these patients are going to be on mechanical ventilators. So the treatment is steroids plus supportive care in form of mechanical ventilators. They are not able to breathe because of hemorrhages in their lung. And plasmapheresis. It is very difficult to save these patients without plasmapheresis. So steroids and plasmapheresis with supportive care for the lungs, that is mechanical ventilators. Right? Okay. So that is that I have to say about overall glomerulonephritis. I can take your questions now, or if you don't have any questions, I can start with the next topic, but I'm just going to hold on and see if there are any questions. If a patient has glomerulosclerosis, will we still do a biopsy? It is like asking chicken pehle aayega ki dusra kya hota hai, anda. So how will you know that there is glomerulosclerosis? You will know that there is glomerulosclerosis only after biopsy. Glomerulosclerosis, pay attention to what I'm saying. Now, don't listen to half of what I said and then ask a question. So pay attention to what I'm saying. Glomerulosclerosis is something that is a biopsy diagnosis. I cannot look at the patient or any other non-invasive test and say that the patient has glomerulosclerosis. You are right in the fact that if someone has already developed CKD, I shouldn't do a biopsy. But you do remember then that the marker of that CKD was a shrunken kidney. So yes, if you ask me that if there is a shrunken kidney, will I do a biopsy? I will say no, I will not do a biopsy, because by then I have lost the opportunity, the window to treat this patient with steroids or something like that. But if the kidneys are normal size, then without doing the biopsy, I will never know whether it has reached the stage of glomerulosclerosis. So don't give steroids, don't be aggressive in immunosuppression. Or is there still active inflammation where I have to be aggressive in my immunosuppression so that it doesn't progress towards glomerulosclerosis, right? So remember, what we are teaching you, we are telling you as if we know everything. Absolutely wrong. We don't know what's happening to the kidney. It's only after I investigated and know what's happening to the kidney. So I will have to take my judgment based on non-invasive tests. Glomerulosclerosis is the effect of my test, not the reason of my test, right? The reason of my test was having a normal sized kidney. Okay, so it's a little tough question here. I would straightforward say that I am not very sure of the answer to this question, but it's a good question. I'm going to read it out. That you told us that hematuria and IgA nephropathy is preceded by an infection. So can leprosy, interstitial pneumonia, or herpes infection, which was listed in the differential diagnosis that you wrote down, can that lead to IgA nephropathy and therefore show IgA deposits? So this is a tough question because all of these conditions can be associated with glomerulonephritis independent of IgA nephropathy. So all these infections might have other forms of rare, these are not common, but rarely these patients could have other, glomerulonephritis like membranoproliferative or membranous kind of glomerulonephritis. These conditions could present with that. And there, if you find IgA deposits, it becomes really tough to say, was this IgA deposit because of leprosy, but the glomerulonephritis is not IgA nephropathy? Or is this IgA nephropathy and that has been preceded by this infection? It's a tough question. We really can't say that always I know the answer. But if the clinical profile fits in, so for example, if I have leprosy, which maybe with an RPGN-like picture, I would have to consider maybe with IgA deposits which are significant, I might have to call it like IgA nephropathy. But if you look at the total number of cases of IgA nephropathy, and if you ask me how many times would I get really confused with these differentials of leprosy or something, I would say maybe the number is less than 1%. So let's come to the conclusion. One, I don't know the answer. Two, in routine, this wouldn't confuse you. In routine, you will have preceding URTI or diarrhea followed by hematuria and IgA deposits. You still need to remember them because it's possible that the patient had leprosy and that's why there were IgA deposits and you labeled it as IgA nephropathy where it was not IgA nephropathy, right? So I hope I have answered your question there. Can the abnormal glycosylation occur in DM as well? Not really. Actually, these patients don't have hyper or more glycosylation. They actually have less glycosylation than usual. So we labeled it as abnormal, but it's not quantitatively more. It's actually quantitatively less and a different quality of glycosylation that occurs to these patients. So no, this is not the same as what you expect to see in diabetics. How is GPS a type of vasculitis? It is a type of vasculitis because the glomeruli itself is vessels and it is damaging those vessels. So right now you are studying this disease from glomerular diseases story. But when you look at the story coming from vasculitis story, you will find that GPS finds a mention in that list also because it is actually damaging the blood vessel. The basement membrane that is being damaged is of the blood vessel. So it is also classified as a vasculitis. It doesn't really change your treatment, but you have to remember GPS can fall into two different textbooks. You might read it in the textbook of nephrology and you might also read it in the textbook of immunology or rheumatology, right? So it's in that crossover between them. Will GPS affect elderly patients with history of smoking? Yes, I mean, it can affect elderly patients with history of smoking. That history of smoking is important because it is believed that in smokers, it predisposes to alveolar basement membrane damage as well. So elderly, they might have a high associated smoking, yes, but we still find that in elderly, the disease tends to be less aggressive, less damaging to the pulmonary system than in adults. That doesn't, of course, as I have already said, it doesn't mean it's always that way, but these are proportions. Proportionately, it's a younger patient who is more likely to come with that. Why does GPS affects only lung and kidney? Let me reverse the question. I'm sure a lot of you have that question. Why does GPS affects only lung and kidney? I would say that a disease that affects only lung and kidney is what we call GPS. I repeat what I just now said. It's not GPS affects lung and kidney. It's like we have classified a disease which affects lung and kidney as GPS. If it does one more funny thing and affects something else, we might change the name to lupus. We might change the name to vaginous. Remember, these are syndromic diagnoses that we have made. Right? This is the real answer as I believe it. There is an answer that is more easy for undergraduates to digest, not the one that I gave. I'm sure this answer is not digestible to a lot of you at this stage. So I'll give you an answer which is digestible to you. And that answer is, well, the antigen which it is affecting is exclusively present in the glomerular basement membrane and in the alveolar blood vessel basement membrane, right? So that is why perhaps it affects only kidney and alveoli, but I'm not very convinced by that answer myself. I believe there is more to that story. We classified the disease that way, and then we found out, okay, this antigen is specific. We might be in for a surprise. 50 years down, one of you might prove what we thought of GPS was wrong, that there is something else to GPS. That's how science evolves. But today we believe and classify it. Can GPS affect other blood vessels also? As of now, as I just now said, no, we classify it when they are affecting these vessels. Leptospirosis can also cause hepatorenal syndrome. So how will you differentiate it? Leptospirosis has its own test. So when I say differential diagnosis, that means if you are thinking in terms of leptospirosis, do the test for leptospirosis. Don't send the patient for, so it would be foolish of me to get a patient of hepatorenal syndrome and I send his blood for anti-GBM antibody, but don't send it for malaria parasite. That is the mistake that you are supposed to avoid when you know the differential diagnosis. So now that I know that the differentials could be leptospirosis, I'm going to evaluate the patient for leptospirosis before I kind of send the anti-GBM antibody. Does GPS present with hemoptysis first? No, there is no first and second here. It's possible that on the first day you have no hemoptysis, it happens after third day or fourth day. It's also possible that on the first day itself the patient had hemoptysis but no renal involvement and it happened over the third or fourth day. Diseases evolve and that's why it takes time to diagnose. It's not possible that the patient comes to you with the textbook picture every day. If he has come to you with both the kidney fired requiring hemodialysis and lungs fired requiring mechanical ventilation, chances he's not going to see the next day. You might not be able to save that patient. Even you want that the disease should come at a speed where you are able to see the evolution and stop it. If the patient already came with both the organs fired, the chance of you saving that patient at that time actually has dropped down very significantly, right? I'm afraid of patients who come to me with two system involvement. One system involvement, I have some chance of saving. More than one system involvement, my chances drop down dramatically. Involve a third system and you had it. Getting that patient off requires nothing short of miracle. And I'm talking about medicine in general, not just GPS. Any system, two systems involvement makes it dangerous. I said that GPS affects two age groups. One is young, which is the other. Other is elderly. I told you, right? So elderly, it doesn't usually cause lung involvement. Will we be discussing membranoproliferative nephropathy? No, I wouldn't be describing any other nephropathy now because simply everything else is just causes. I have described the approach to almost all of them. So I'm going to stop my discussion on nephropathies here. All the other forms of glomerular nephritis, please go through. If there are questions, ask me. I would be happy to answer if I know the answers to them, right? Please don't ask me pathology questions. I am not very good with that. If GPS is a form of vasculitis, can it affect other blood vessels? I have answered that just now. No, we classify GPS as a vasculitis which affects only these two sets of blood vessels. If it affects any other blood vessel, I will perhaps not call it GPS. Like lupus, it can affect blood vessels in the alveoli, in the kidney, and somewhere else also, like the brain. Then I call it lupus. I don't call it GPS, right? We classify diseases based on what we see. We have classified GPS in this way. Does GPS resolve completely? It can. Not always, but it can. You give plasmapheresis in time, patients might have a good prognosis. Okay, when they ask next step in management in patients with such complaints, what should the answer be? Okay, that's a very fundamental question then. I have said this, I think, in Pune when I was teaching. I don't think I've spoken of this in Bombay as well or anywhere else. So pay attention to this. Your next best step depends on which step you are right now, of course, right? So I can't jump from ground level to the top floor right now. I will have to take the next best step depending on where am I right now, which means based on the available clinical information, history, examination, available blood, urine, whatever test you had, what is your present diagnosis? If your present diagnosis says that you are looking at a life-threatening condition, like at this time I have information that the patient has chest pain with an ECG showing ST segment elevation. I've made the diagnosis of ST segment elevation in mind. Now my next step based on this step is the treatment of choice. Whatever is the treatment of choice, that is my next best step. But if you tell me that you have a patient who is having mild hemoptysis, but a picture of RPGN, what is your next best step? Now I can't say I'll do plasmapheresis. What if it was lupus nephritis? You can't do plasmapheresis. What if it was malaria? Giving plasmapheresis has no meaning. I still don't have the diagnosis. So my next best step is whatever is your option. If you are talking of an MCQ, then whatever is your option that gives you the diagnosis. Or if you are looking at it clinically, then the next best step is investigate more. And that investigation depends on what was your diagnosis at this step. So if you have made a diagnosis of hepatorenal syndrome or pulmonary renal syndrome, pulmonary renal syndrome, then my next best step would be test for malaria, test for leptospirosis, do anti-GBM antibody, maybe do an ANA. These are my next steps. If you have an MCQ, whichever of this is there in your next step, you answer that. Otherwise, take the next step based on this step. So this is a general outline. I want you all to remember this. Do not fall for questions. Those of you trying to solve MCQs because you have a lot of time, my first advice, stay away from MCQs. But that said, if ever you are looking out for a question and that question says, what's the next best step? First, decide what is your present step. Where are you right now? Is it an emergency? So treatment. Not an emergency. Diagnosis not known. A diagnostic test of choice. And there, by the way, if this here, this step, this question, you had multiple options. You could do malaria, you could do anti-GBM, you could do this, that, whatever. Sometimes you have thought that this is ILD. Then what's my next best step? Clinically, you're thinking Velcro crepitations, clubbing, shortness of breath. I think this is ILD, interstitial lung disease. What's my next best step? Well, then the next best step is the investigation of choice. You had a diagnosis in your mind, you're thinking this looks like ILD, then the next best step is the investigation of choice, which could have been HRCT chest, right? So think of it that way. Okay, so I guess I've answered all the questions. I said this, okay, I'm not going to discuss any other nephropathy. So yes, I'm not discussing membranoproliferative, neither am I describing membranous nephropathy. So I'm not describing any other nephropathies. If you have any questions, please go through and ask. The reason I'm not describing any other nephropathy is they do not differ in the clinical presentations. In medicine, it doesn't change much. In pathology, membranous is different from membranoproliferative. In medicine, that would be either nephrotic syndrome or nephritic syndrome followed by a biopsy. And that biopsy showed me that there is membranoproliferative or membranous, and then I need to know the causes. So there are tables that you will have to go through. They are there in all your textbooks. It doesn't make sense that I spend time dictating you tables after tables, causes of this, causes of that, causes of this. It's very boring and doesn't lead to anything. And those causes, remember, come after the biopsy report, not before the biopsy report. And then the treatment is the same, steroids plus immunosuppressant, right? So I'm not going to the rest of them because there is a lot of overlap in, it's the same thing, repeat again and again, except the causes. So go through the causes of all of them. If you still have questions, please do ask. The differences are in pathology, not in medicine. Okay. That was a lot of talk. And it looks like in my lecture of hypertension, I've spoken a lot about glomerulonephritis till I reach hypertension. So let's do this. I'm going to start with hypertension. We'll talk for, we have some 5-10 minutes till 4, but I'll extend a little by 10 minutes more. So I'll talk for another 15-20 minutes. Let's talk about basics about hypertension. What are the mechanisms that are involved? What do we understand of the pathophysiology, right? So please start with a new section, very often related to two topics, cardiology as well as nephrology, systemic hypertension. Please write down systemic hypertension. Systemic hypertension. Keep on getting confused with this. Yes. Okay. So when we are talking about systemic hypertension, well, first things that we need to remember is, of course, I guess most of you know this, it's a very common condition. Systemic hypertension is a very, very, very common condition. And when we talk about hypertension, I will not talk of its definition yet because that's a controversial story. Please make a note of this. In the pre-industrialization area, now this is a very big problem. You have to understand that if you read your PSM carefully, I'm sure some of you are smiling right now that I've come back to the story of PSM, but if you have read PSM carefully, or if you are reading PSM carefully, you'll realize that there are these continuous variables and there are these discrete variables, so on and so forth. Hypertension is blood pressure which is more than usual. But what is usual is a very difficult question. To diagnose something as usual, I will have to say that beyond this level, people are going to have problem. That's one way of diagnosing it. Or I will have to say that, well, most of my people in this community have this level of blood pressure. If I use this second approach, that most of the people in my community have this level of blood pressure, that normal has changed with time. As industrialization has come in, as the population is aging, as the stress in life is increasing, as the pollution is increasing, as the lifestyle is changing, the normal of the population is also increasing. So where do we call something as normal? We have to go into the history and we see that before industrialization happened, that is like close to 200 years back, the average blood pressure of that time, whatever records we have, was much lower than the blood pressure of this era. We also have now from 2015 onwards, some but a strong evidence to say that maybe that blood pressure was something at which the risk of death, cardiovascular morbidity, stroke was really less, and that has increased now, right? So that still keeps the definition of what should be called hypertension as a debatable question. Of course, there are guidelines. I'll talk about them next time. But remember, those guidelines are not word of God. That is what we human beings, we scientists are deciding, okay, let's call this as hypertension. But you should know that in the pre-industrialization era, the average blood pressure was 115 by 75 or less than that. So please make a note of this, that in the pre-industrialization era, the blood pressure was less than or equal to 115 systolic by 75 millimeter of mercury diastolic. Now, whether to call this as normal is controversial. I'm not saying that everybody who has any blood pressure above this should be called as abnormal, but I'm saying this was definitely thought to be the normal for a very long time. I mean, at least in the long past. Now, whatever it is, we can divide this hypertension into two types. We can say that the hypertension is primary hypertension, also known as essential hypertension. Well, there is nothing essential about it, but we can say that there is primary hypertension or essential hypertension. These are patients where we have no other cause. It is just that with age, the blood pressure has gone up. And these constitute 90 to 95% of cases of hypertension. So essential hypertension, primary hypertension, 90 to 95% cases, we have no other cause. There is just hypertension and that is about it. Nothing caused the hypertension, or at least nothing that we know has caused the hypertension. No correctable factor, right? You can of course correct the hypertension, but there is no correctable factor which caused hypertension. But that means there is a secondary hypertension, which is around 5% of cases. Please make a note of this. What are these correctable, so to say, not always, but very often correctable factors of hypertension? Right? What are these causes of secondary hypertension? Well, there are many causes over here, but to keep the list simple, you can have renal causes, that the problem was in the kidney and hence the blood pressure started mounting up. And here one of them is of course chronic kidney disease. You remember our discussion on CKD, and you remember that in CKD we had said that CKD causes cardiovascular complications. One of them was hypertension. But I guess you also remember that hypertension can cause CKD. This is a tricky story. No, please make a note of this. CKD causes hypertension, but remember, hypertension can also cause CKD. So it's not always possible to say that the patient has secondary hypertension. Please make a note of this. In the case of CKD, it is not always easy to say that, okay, this patient CKD came first and that patient hypertension came first. You might not always get that much data from the patient, right? Sometimes you might be able to show it very clearly. Maybe it was, patient was very meticulously under your monitoring, or the patient himself was a doctor and checking his blood pressure very frequently, and you know that, okay, CKD came first and then came hypertension, but it could be a tricky association. Another condition is autosomal dominant polycystic kidney disease. Now, this is definitely a kidney disease which causes hypertension, autosomal dominant polycystic kidney disease. Just like you can have renal, you can also have something known as renovascular hypertension. You might want to club them together. You can even separate them out. And here there is an interesting name I would want to bring to your notice, known as fibromuscular dysplasia. Fibromuscular dysplasia. I might not come to this condition again, so I want you to write down a few things about fibromuscular dysplasia. Very often this is a disease of young women. You would very often find this to be a 25-year-old girl or somewhere below 30, so young women. The exact cause is not known, but there is fibrotic lesions in the renal artery and its branches. There are fibrotic lesions in the renal artery and its branches. And as a result of that, if I show you the renal artery or its branch, let's say this was the branch of the renal artery, and there were these fibrotic lesions which started happening here. These are not continuous, but they are kind of, you might say, at different areas. The result of this is that the artery will become like this. It will have areas of stenosis. Please make a note of this, that these patients, have fibrotic lesions within the renal artery, leading to a beaded appearance, of the renal artery or its branch. And this beaded appearance can be diagnosed by doing a renal angiogram. Angiogram means you send a dye within it, and in the dye you see that it shows a beaded appearance of the renal artery. So a young female coming with hypertension, think of fibromuscular dysplasia. The diagnosis is done by doing a renal angiogram, and on the renal angiogram you get a beaded appearance. Why did this fibrosis occur? Nobody really knows. The treatment of this is dilatation, surgical dilatation of these areas. So you'll have to dilate open these areas. That's the treatment of this fibromuscular dysplasia, right? So just few points that we need to remember about fibromuscular dysplasia, which is a type of renovascular hypertension. Another type of renovascular hypertension is, of course, renal artery stenosis. Renal artery stenosis. You could have other secondary causes like obstructive sleep apnea, other secondary causes of renovascular hypertension, secondary hypertension could be obstructive sleep apnea. It could be diseases of the blood vessels like coarctation of aorta. It could be endocrine causes. Please mark these as important. It could be endocrine causes which present with hypertension. And amongst endocrine causes, remember thyroid disorders. Both hyperthyroidism as well as hypothyroidism can cause hypertension. Please mark this as important. So if you get a patient of hypertension, don't forget to look at his TSH. Both hyperthyroidism as well as hypothyroidism can lead to hypertension. So very recently, just last week, one of the family friends of ours is an elderly gentleman, and he was very tense that his blood pressure has never been a problem. He is absolutely fine. And during this corona pandemic, he just couldn't go out. But few days before that, he was detected to have hypertension. And then a physician had called him back, but he couldn't go there because of the lockdown that came. So he called me up, and we had a discussion on this same video conferencing platform. And then I told him, why don't we get you tested? Let's do some basic cardiovascular workup, and let's do thyroid also. Turns out to be that the gentleman is now hypothyroid. So he was also relieved that, okay, now at least I know the cause, because he's been very cautious and health conscious. Ki bhai, I shouldn't have a problem. But look out for such secondary causes like thyroid, right? Other conditions, again, endocrine conditions, could be conditions like acromegaly. And a condition which is very popular, though not very common, is pheochromocytoma. Pheochromocytoma, right? And last but not the least, your job doesn't end over here. Do not forget that it could be drugs which can cause hypertension, and topping the list over there are steroids. Please mark them as important. Steroids or glucocorticoids are a very, very, very important cause of systemic hypertension. If your patient is on steroids, monitor for systemic hypertension. Steroids can cause systemic hypertension. Other drugs could be NSAIDs, non-steroidal anti-inflammatory drugs. There's a big list. I'm just giving you some of the common drugs. Steroids are a common class of drug. NSAIDs are a common class of drug. One drug that we had seen the other day was cyclosporin. Cyclosporin can also present with systemic hypertension. Tricyclic antidepressants, again a very common class of drug that is being used. Tricyclic antidepressants, right? There could be a longer list. If you go through your textbooks, there would be other bigger lists. Please make a note of this. In all conditions, essential hypertension is much more common, but secondary hypertension, look out for some causes. And these are the causes that you are going to look out for. And the most important, if someone is to ask me, it is thyroid, because the rest of it is not so common. Thyroid is by and far much more common. CKD, of course, you will have the history, but rest of it is not so common as much as thyroid is. Right? Okay. Now,
I'm a little in dilemma. Should I go ahead or not go ahead? It's the next thing is a big discussion. I think it makes sense that we stop. I'm sorry, I labeled the lecture as hypertension. I couldn't really complete it. Let's stop over here. But tomorrow we meet again at 3. And I think tomorrow's lecture we might spill over a little. We will go up to maybe 4:30 tomorrow, so 1.5 hour lecture. And tomorrow we will talk about details of hypertension. I would be discussing what are the mechanisms of hypertension. Presentation wise, well, most patients are asymptomatic, but what are the treatment strategies? That's really the tricky part and a little confusing part of hypertension, right? So till then, if there are any questions, I think I'll just go through if there are any questions that you have typed down. Okay, so one question I have got is elderly patients do not present with elderly patients of GPS do not present with hemoptysis. Then why would you clinically diagnose an elderly patient with only nephritic syndrome as GPS? Because it's one of the differentials. So GPS is not equal to renal pulmonary syndrome. GPS is one of the renal pulmonary syndrome. That doesn't mean that all patients of GPS should have renal pulmonary syndrome. In fact, even in young adults, if the patient has rapidly progressive glomerulonephritis without having pulmonary hemorrhage, GPS still remains in my differential diagnosis. If an elderly patient comes with nephritic syndrome, GPS still remains in my differential diagnosis. Where you have written nephritic syndrome, please go back and read. You have mentioned GPS in that as well. So it is a differential diagnosis of nephritic syndrome. I will think of it because it's a differential diagnosis of nephritic syndrome. And remember, when I don't have any other cause, I will end up doing a biopsy. And if I do a biopsy and I'm showing an immunofluorescence on the basement membrane, I've still called it GPS, right? So why would I think of it? Because it's a differential of nephritic in those patients. How does hypothyroidism and hypothyroidism cause hypertension? Sorry. So those of you interested, make a note of this. Hyperthyroidism causes hypertension primarily by causing increased cardiac function. So the stroke volume increases and that contributes to hypertension in case of hyperthyroidism. Hypothyroidism causes damage to the blood vessel. It causes thickening of the blood vessel, narrowing of the blood vessel, and causes diastolic hypertension. So hyperthyroidism increases the stroke volume, and that is its primary mechanism of causing hypertension. Hypothyroidism causes increased peripheral vascularization by causing deposits within the blood vessel and narrowing the blood vessel, and therefore causing makes the blood vessel more what do you say, less distensible. The makes of I won't use the word fibrotic, maybe more firm, and that's why it doesn't allow the blood vessel to dilate easily, causes hypertension. Right, so I do not see anyone typing anything at this moment. Okay, fine. So I'm going to hold over here and let's meet tomorrow at 3 o'clock. Tomorrow's lecture again would be hypertension. It would extend a little from 3 to 4:30, right? Thank you so much. Take care of yourselves and your family. Do not venture out. I'm sure you're not doing that. Continue your studying. And if there are any questions, feel free to discuss with me. Goodbye and Jai Hind.